Hello, I think we're going to go ahead and get started. My name is Kaylee. I'm Manager of Education here at Oley. Thank you so much for joining us today for our second general session, Connecting the Dots of Advocacy, Communication, and Care Transitions and Nutrition Support. As we've heard previously throughout this conference thus far, patients on home nutrition support rely on intricate webs and teams of healthcare providers, caregivers, industry, and other professionals to ensure that they receive safe and effective care. And we've heard that communication gaps, issues with reimbursement, and other system challenges and inefficiencies often leave this already vulnerable patient population struggling to access the support and care that they need. So today, we have drawn together a diverse panel of experts, caregivers, clinicians, industry, and NHIA representation to really touch on some of these critical areas of opportunity with you all today. So with that being said, I'd like to kick it off and hand it over to our first speaker. Jeannie, you want to come on up?
Hi there, I'm Jeannie Counts. I'm the editorial director at the National Home Infusion Association and the editor of Infusion magazine. And today I want to take you behind the scenes of nutrition support. I have no disclosures for this presentation. And here are the learning objectives. So you might not see them, but behind every person receiving enteral or parenteral nutrition is an entire team working tirelessly on your behalf. They're drawing and checking labs, fine-tuning fluids and micronutrients, compounding PN solutions, shipping materials, and yes, spending countless hours battling insurance companies for coverage, and they do that last one quite a bit. In home infusion, that team includes pharmacists, nurses, dietitians, pharmacy technicians, and reimbursement specialists, and their mission is to make sure that your therapy is clinically sound, safe, and accessible. But so here's a question: what support does this team need, and where do they find it? They need to stay current on a wide array of complex, interconnected issues. I tried to do a little map of that. You can see it's incomplete. But there are several associations and groups working in this space to develop, to share cutting-edge knowledge and best practices and advocate for policy changes and things that will make patient care better. NHIA works hand in hand with organizations like Oley, Aspen, INS to create a network of support that those professionals can use to draw on. So let me show you some examples of how this ecosystem works. Our first priority is education. Working on NHIA's magazine and with our communications, I see this firsthand. Every year, we dedicate an entire issue of Infusion magazine to nutrition support, and we coordinate that with Aspen and Malnutrition Awareness Week so that we can try to raise awareness and offer additional CE for professionals seeking licensure requirements. And through our webinars and conferences and other things, we provide other continuing education opportunities and keep people up to date. So research is another way that team members stay informed. Through our foundation, NHIA operates an industry benchmarking program. We collect and analyze data on clinical and operational metrics, and they can be mined to analyze insights that will improve patient care. So I'm going to share a couple of key points from 5 years of home parenteral nutrition data. These findings probably aren't going to surprise anybody in this room, but the reason that they matter is because when we have data, we can go from, yeah, we know that, to here's proof that we need to do X, Y, or Z. This evidence helps all the groups working in this space to push for policies and practices that improve care. And so here's what some data reveals about the critical first 30 days following a hospital discharge. Nearly 37% of PN patients are readmitted to the hospital within the first month of therapy. And even more telling, 2/3 of those readmissions happen in the first 14 days, and a quarter of them happen by day 6. So we know that the transition from hospital to home can be an overwhelming experience for patients who are new to therapy, and this research just underscores how pivotal it is to try to offer support to families, caregivers, and make sure that the communication is impeccable as we're handing things over from the acute care to the outpatient setting. The numbers also tell us something important about the complexity of home parenteral nutrition. It demands significantly more pharmacist time and attention than other therapies. Most of that time goes to patient assessment, drug preparation, and compounding. And that's because, as you know, PN is really complex, and it's made up of 25 to 30 different ingredients, many of which have been on shortage at some point. And this level of intricacy just requires specialized expertise and intensive management. Patient satisfaction surveys tell us that home PN patients are highly satisfied with home infusion services and just slightly higher than patients on other therapies. We think that that's probably due to the long-term relationships that a lot of patients develop with their caregivers. And, you know, I know personally I've spoken to some consumers who've been working with the same pharmacist for years or even decades. Some patients are able to go off of PN, and that data tells us that home infusion is effective. I always say effective, I mean effective, in helping them complete certain courses of care. So nearly 2/3 of HPN patients who are discharged from therapy cite therapy complete, and that indicates to us that they were successful and that they are transitioning probably back to some other form of nutrition. In 2022, our foundation launched a peer-reviewed journal that's designed to push many of these kind of findings out into the broader healthcare community. And we recently applied to PubMed, the National Library of Medicine's searchable database, to be listed there. And when we achieve that, we will be able to really reach clinicians working in healthcare worldwide. So that'll be really good to get that data out there and maybe inspire other people to submit to us. Professional and trade groups also advocate and advise to influence policy on behalf of patients. Recently, NHIA, our reimbursement experts, partnered with the clinicians at Aspen to tackle Medicare's outdated clinical coverage criteria for home PN. And after years of working through that redetermination process, and it was a long time, they were successfully able to convince CMS to update their criteria. So you can see this is a little older data. This is from 2022. But just 11 months after that criteria changed, the percentage of Medicare beneficiaries qualifying for home PN went from 1 in 10 to 5 in 10. So that is like real people getting access to life-sustaining therapy who could not get it before. With all patients, especially those on PN, it's critical for associations to take on emerging threats to vulnerable supply chain, which we've seen over and over again. NHIA joined forces with some affiliated groups to urge the FDA and state pharmacy boards to investigate how medical spas are impacting the critical drug supply shortages. And this is, you know, those places, those IV drip bars that are helping people get over their hangovers and stuff. And there have been a couple of state boards of pharmacy. I think Ohio most recently joined with the nursing board and their medical board to make a statement about how these people need to be more licensed. These businesses should be licensed properly. We're not quite at the regulation point, but they're noticing. When crisis hits, associations also respond but pretty quickly. When Hurricane Helene knocked out that manufacturing plant down in North Carolina offline, NHIA immediately started working with the government and Baxter to minimize patient care disruptions and ensured continued access to IV therapies. And we also created practical guidance for our pharmacies so that with specific recommendations for conserving products when they're in their compounding and in the administration methods so that they could make those supplies last longer. We've heard from patients and pharmacies alike about the multiple issues making it so difficult for PN patients to travel. After researching and writing this article here, with the help of Betty Marie Bond and Beth Gore, I can't even believe so many patients are here. But I do think it's an amazing testament to the power of the Oley community. This is a really complex issue, but NHIA is working with other groups to try to get the attention of state boards of pharmacy and see if we can't untangle some of these regulations. Nutrition support teams are committed to expanding patient access to home infusion, but we need sustainable provider networks to make that possible, and sometimes it's just not financially sustainable for providers to stay in markets, and they have to exit. And many of you have noticed the shrinking pool of providers, first with enteral, now with PN, and so NHIA is documenting the reasons behind these trends so that we can advocate for some solutions. This fall, we have a white paper coming out on the factors that drove the enteral provider market to change so quickly, and we're also going to update a cost study on PN and the cost of compounding a bag of PN, which the last time we did this study from 2016 to 2021 in that 5-year period, the cost increase exceeded 50%. So we all know drugs and supplies are not going to get any cheaper anytime soon, so we want to document this as well. The issue of shrinking networks inspired a huge collaborative push at the state level this year. In Colorado, the Medicaid reimbursement for PN became so inadequate that the provider network shrank from 6 pharmacies to just 1 single pharmacy. And so representatives from Oley, NHIA, infusion provider companies, patients and families all went and lobbied for a bill that did end up passing the legislature and was signed, that hopefully is going to bring some of those reimbursement levels for the state Medicaid program up and allow some businesses to come back into the market. And it's also important to advocate with commercial insurance companies. We want them to adopt policies that improve both patient outcomes and, generate cost savings for them, which is why we like to, that's the thing we like to use to educate them about it. And so we've made some suggestions through, we have an annual list of recommendations that we make. But here's what really drives everything that we do: ensuring patients can lead happy, healthy, independent lives. We know that with proper medical care and support, people receiving enteral and parenteral nutrition can thrive and be independent. And one of my favorite aspects of my job is highlighting consumers like that in Infusion magazine. Sharing your stories reminds all of us and everybody on the care team and the public that there are real people living full, independent lives with nutrition support. So you can see how it all connects: education, advocacy, tools and resources, and groups like NHIA are there to support the nutrition teams that support you. So, here's my references list. And I'm honored to be here for the next day or two, so please, if you'd like to speak with me, I'd love to hear what interests you and some of your perspectives and ways we can collaborate. And now I would like to introduce Jayme. Thank you.
Okay. Good afternoon. My name is Jayme Scali. I'm the mother of 3 children, 2 of which are on TPN. I have over 17 years of personal experience managing life with nutrition support therapies. I also have 7 years of industry experience working as a patient advocate within home infusion. Oh, this slide is new to me, sorry. Okay, so what does it say? Well, those are my disclosures, there. Okay, so today I want to talk about connecting the dots and reestablishing trust between patients and the home infusion industry. Wearing both hats, I see a lot of gaps that are happening, especially in the last few years, with our ever-changing market and with just so many challenges. So I basically just want to share both an industry and patient perspective and see how we can start collaborating and work together. Oh, wait, hold on, sorry. So we're going to acknowledge the hardships within home infusion. We're going to review the impacts that it has on patients. We're going to do some perspective sharing, and then we're going to figure out how we can start working together. Sorry about that. So the first thing is the hardship within home infusion. As Jeannie alluded, there are the ongoing reimbursement rate challenges that create barriers and access to care. The overall rate is significantly less for the average cost to maintain a home parenteral nutrition patient. The specialty components, as she said, either have tiered pricing or has gone up in pricing, but yet reimbursement rates seem to stay stagnant. And specialty products such as dressings and other ancillary supplies are often not covered with the allocated daily rate for therapy. So as a patient, before I entered the infusion industry, I thought, okay, my child has a lot of allergies, she needs a lot of specialty products that go against the standard formulary list. These are something, like I have insurance, I have great insurance, this is something that I should have access to. And I never really understood the pharmacy pushback. Because in my mind, this is something that I should have. And then as I started working in the industry, I realized it's a flat rate. So whatever your insurance is contracted to pay, that's it. And once you exceed that, from door to door, then you can be either barely breaking even or sometimes even negative gross margins, which creates challenges. We also have, as I said, the increasing rate of supplies and companies exiting the market because of this. So companies are being forced to review profitability to determine how they can deliver value-based care for their patients while still being able to cover staffing costs. Many have chosen to reduce their footprint with home parenteral nutrition just to be able to ensure quality care while still maintaining business growth. Some have chosen to disengage with home parenteral nutrition altogether and focus on profitable types of therapy, which ultimately is increasing a barrier to access of care. And then we have our drug shortages, which we are all very familiar with due to natural disaster, recovering from a global pandemic, and the popularity of recreational infusion boutiques. So how has this impacted our patients and the industry? As we saw when the hurricane hit, some patients had that were only hydration, ended up not being able to receive their hydration therapies at all. Despite clinical need, these patients had to go without. Some people, their overall TPN was reduced, or their days of the week that they had access to their PN was also reduced. And also, our patients, in some cases, experienced extended stays in the hospital due to lack of finding a provider as a start of care or even a resumption of care. And our patient choice options is shrinking, which creates a domino of the companies reducing staff, which subsequently limits growth, and them being able to take on a higher patient census. So, again, working in the industry and seeing comments, within our community, it's like, why can't they take on new patients? Is it me? Is it my disease state? And a lot of us have felt abandoned and isolated. And I like to think about it as ratios for daycare. So if any of you have children, and there's that coveted daycare spot, it's kind of similar. In order to maintain safe, sterile compounding, we do need to think about what our pharmacy and our staff can handle in order to do what they need to do safely for their patients. So it was hard for me to hear, as a patient, and it creates anxiety, but I think that we need to understand that as patients, that we want things done, but we want them done safely. So we have to take that into consideration. Our industry, infusion companies are also constantly reviewing their payer contracts and renegotiating these rates so that they can ultimately support their patient population. And what we're finding is that oftentimes contracts dissolve. I've been impacted by that directly, and I have what I think is great insurance, and I was left in a spot where no one wanted to provide care for my 2 children, which is a terrible feeling because I can't go to the store and provide what they need. I need to rely on a sterile compounding pharmacy. So then it results in either trying to find a new company, and then with the companies that are exiting the market altogether, it's in some parts of the world, of America, it's creating medical deserts where there is no local ability to get care. Patients are also experiencing stricter formulary guidelines with those specialty items that I was talking about, and really not being able to make as many exceptions as they had in the past. And I really think that that's become a hardship because ultimately now families, if it's a product that's really working for them and they really need it and they can't get it from their home infusion company, they're now buying it out of pocket, which is increasing the financial burden for their patients and families. So now this is the patient perspective, and I feel like we've all, if you're a patient or a caregiver, I feel like we've all said it, thought it, or heard someone else say it. My insurance is paying for the supplies, why can't I get what I want? My infusion company just dropped me. I'm afraid I'm going to starve to death. Why can't they take on new patients? Don't they want my business? I have no control over my care, and all these companies care about is the money. Now let's look at how the industry perspective goes. Gross margins barely break even when servicing a PN patient. Insurance plays a flat rate for the therapy per day, and every specialty item added may take us into the negative. Cost of supplies is increasing, yet the rate of reimbursement remains the same, making it difficult to provide quality care for our patients. To better serve our patients, we need to hold steady, not add more patients, to ensure we have enough product and supplies for our existing customers and maintain safe pharmacy staff to patient ratios. And it's not sustainable to care for complex patients with high acuity needs in a market that is not sustainable for growth of the population. So how do we support each other? How do we initiate a value-based care that in a way that benefits both the patient and allows the industry stability and growth? So value-based care is, in a nutshell, improving quality of care, efficiency of services, reducing costs, and addressing health-related social needs. Promoting a change like this in the existing reimbursement models so that financial responsibility and the risk of delivering health to our patients is incentivized with the best interests of the patient while protecting the financial interests of the infusion industry system. Investment in this infrastructural change will promote value-based care that will ensure optimal outcomes while managing costs, prioritizing value-based payment care models versus quantity. So how do we create a value-based care plan? What does that look like? What does that even really mean? So I think that that's where we can help and really be prevention-focused, like Jeannie had mentioned, focusing on staying curious, asking our patients what they need, why they need it, and supporting their needs. Considering social determinants of health, removing the bias, the judgment, and the paternalism mentality of care. Evaluating needs assessment and clinical rationale, and treating with quality over quantity. Also focusing on patient education and early literacy to empower our patients with the tools for self-advocacy. Encourage peer support and the connection to the community and cross-sector partnerships, and having greater support for our care teams, because they need care too. Also, we need to try to minimize the us versus them mentality, and I see this so much, me versus them, taking it personal, and it is very personal because it's life-sustaining, but at the same time, really asking that why. Like both patient and industry alike need to be asking, why is this happening, versus just being reactive. So we need to allow for transparency and vulnerability. We need to never stop asking why. And before you ask the what or the how, just remember to ask why. Once you discover that, the how will come, the what will come, and the how will come after. So this is something patients can do, which is something that I started doing about 7 years ago when I entered the industry, is insert yourself and become an advocate. So speak up and share your story, create awareness as much as you can. Engage your local state representatives and legislators. Volunteer to participate with local organizations for Days on the Hill. Ask your hospital system if they have a public policy team and what events they have and if you can participate. And also participate in awareness days. And know your resources. So here's just a few that I feel are really important to our community. So it's always good to familiarize yourself with them and make sure that you know who they are and that they know who you are. As patients, a lack of control and helplessness adds to the ongoing stress and anxiety of being complex. We need to be informed and be given the opportunity to advocate for better care. We need transparency and disclosure of the realities facing our community. We need to be seen as a member of the team and be better equipped with knowledge to be better stewards in the care that we're receiving. As industry professionals, we need to support our patients and elevate their stories to promote change. We need to have the resources available to provide quality care for patients. We need the reassurance that our patients know we do care, we only want to help, and our main objective is them achieving a high quality of life. So in closing, I know it's been a constant transitions and uncertainty. So now more than ever, I feel we need to really unite and focus on ensuring quality patient-centered care. To our industry leaders, I want to thank you for all that you do. You're constantly fighting the fight and supporting patients and families. Please don't stop being curious when caring for your patients and continue to advocate for a way to increase access and remove the barriers to care. And to our patients and families, you are the true inspiration. You're the reason why many of us do what we do every day. Share your stories, elevate each other's voices, and never stop asking questions and advocating for better care. But also just remember that your care team needs to feel valued and cared for too. Thank you.
Hi, everyone. It's really hard to follow that. My gosh. So just so I get an idea of kind of who we're working with, if you feel comfortable, could you raise your hand if you're a clinician or in industry? Okay, nice. How about a consumer, caregiver, care partner? Okay, so it seems like kind of roughly half and half. Anybody serve more than one role, wear a couple different hats? Okay, there are some of us, I see you. So I'm Amanda Gilhool. I'm a registered dietitian, and I'm also a care partner. So it's really exciting to be here today and to kind of see everybody's experiences, see myself reflected in more than one way. And we're going to be talking a little bit about my experiences today. I have nothing to disclose, not that interesting. So I definitely want to talk a little bit about long-term nutrition support, especially enteral nutrition, which is what I'm most familiar with in a personal capacity. And then also talking about strategies to communicate between clinicians and either caregivers, consumers, since I have been on both sides of those types of conversations. So Janine kind of had a similar idea, slightly different graphic. It was really hard to do and kind of try to be a little comprehensive. But especially when I think about the broader landscape of healthcare, there are so many different factors influencing all of us. So as a consumer, of course, you have hopefully the very center of this web here. You're going to be interacting with your care team, with your physician, with your dietitian. You also have your life. You have your friends, your family, school, work obligations, your community, all of your values and goals in life, access to your supplies, access to the right therapies, information, community. There's so much affecting your life. And we have the same as clinicians as well. So when I see somebody, I'm talking to them about what's going on with their nutrition, I also know that I'm accountable to the facility that I'm working in, our policies, my department, any of like our normal workflow for the day, time constraints, financial constraints if there are any with what I'm doing with a patient. Outside of that, we also have professional recommendations, best practices, laws that influence what we're able to do, how we operate on the day-to-day. And I really just wanted to emphasize that we're all working within this web together. So no one person is only influenced by the person directly in front of them or the situation that's directly in front of them. And I think it really serves us well to all remember that and to acknowledge that when we're working with one another. So when I am speaking with somebody in a professional capacity, I kind of have my dietitian hat on. I probably have my papers and my pen. I walk into the room, see the person in front of me. You've probably had very similar experiences if you've been on the other side of this interaction. And I go into dietitian mode. I will be completely honest with you. I am not at that point a care partner myself. I am not somebody's daughter. My father has a GJ tube, so that's where I get my personal experiences from as a care partner. I'm not, the person who was sitting on the bus next to somebody riding into work that morning. I am in dietitian mode. And just to give you a little bit of perspective, if you are more so on the consumer or the caregiver side, I have kind of my mental checklist. I have my perspective that I'm bringing to that conversation. And so I just wanted to kind of clue you into what my state of mind might be at that point. So first and foremost, I want to know that you're getting the nutrition that you need. If you're not, let's leave everything else to the side until we can really address that and get that nailed down. Because if you're not getting what you need, I'm not doing my job right. And you are at risk of developing all sorts of complications, malnutrition, longer length of stay, infectious comorbidities, all of that really bad stuff that we want to prevent. So first and foremost, I want to know that you're getting what you need. Now, how do I find that out? Hopefully, it does not take too long, because I wouldn't want to dwell on that for too long. I want to address the whole picture. However, let me know if you know, and I really encourage you to educate yourself with a lot of the incredible resources that Oley has made available to us. Know what your formula is, know how much you get. If you're on TPN, I think somebody mentioned this yesterday, take a picture of the label if you ever have a spare second and it comes to mind. Even if it's slightly outdated, at least we kind of have a starting point to use as a launching pad to get us to a better space where we can say, okay, based off of what you told me, you're getting about X number of calories, you're getting about this much protein, this much hydration. All of those based off of our conversation or any sort of calculations do seem to be appropriate for you. Beautiful, check mark. Let's move on to the rest of your life, because you are not just defined by what you get into your body or your nutritional status. So right off the bat, I want to make sure that that's taken care of. Now, I also want to know what challenges you're facing. So if I'm talking to somebody and they're like, yeah, you know, this is what I'm doing at home, my weight's pretty stable, I'm like, okay, cool. What else is going on? And then if we start uncovering like, oh, there's, you know, you're having terrible bloating, you can't finish your feeds because you feel so uncomfortable by the end of that, but you just manage to get enough in to maintain your nutrition. Those are things that I really want to know, because those are things that we can address not only to make you more comfortable, but also to make sure that you're more consistently getting your nutrition in and we're preventing any secondary complications or unintended side effects from some potential intolerances that you might be having. I also want to know what resources and supplies are available to you. So not every time do we have the luxury of just directly asking, like, do you have enough supplies at home, especially if there are other more complicated conversations that we need to have at that very moment. However, if you know, let us know. If you know that you're running low on supplies and maybe you need a new script from your doctor, maybe you need to call into your DME company, but you didn't have a chance to before you had to come into the hospital, and we need to make sure that all of your supplies arrive before you go back home, tell us that. We can help you with that. We can make sure that you continue to have the supplies that you need by the time that you get back home, especially if you're currently in the hospital. Or if you run into consistent issues, then we can start addressing that with the rest of the care team and potentially involve other resources as well. Now, the last two on here ideally are going to be part of every conversation that we have, but again, the more efficient that we can be with some of the earlier parts of the conversation, then the more we can get to kind of the nitty-gritty, really emotionally and psychosocial aspects of your nutrition. So what are your priorities? Especially if we're making changes, if you're having to make big decisions about your health, let us know what's important to you. If they're talking about maybe doing a J-tube and you've only had a G-tube before then, it's really important for us to know that you want to be very active and out of the house and you want time away from that pump. If it's really important to you that you're just comfortable and you get to spend time with your family, that could influence some of what we do as well. If financial burden is really high and you just know it's going to be really difficult for you to afford certain equipment, or if you need more specialized equipment, or if you're unsure that you might need more specialized equipment, let us know that that's a concern for you and you're really feeling that strain there, and we can help with that as well. And then lastly, what can I do to best support you? I don't know what you need on the day-to-day in terms of your overall life, but I will do whatever I can to make sure that your proper nutrition goes hand in hand with your real life. And I did include here as well, Oley has amazing resources like this little tube feeding card. So if somebody came up to me and was like, hey, this is what I have, it tells you exactly what I do at home, I would probably have to hold back from kissing them because it saves us so much time. And then, like I said, we can get to the other stuff, the stuff that's more important for your overall well-being than just having to dig through medical records. But if you don't have it, if you don't have that luxury, we will still make it work for sure. Now, as a care partner, if I switch over to that other side of my brain, I do want to know, should we be doing things differently? Especially if you are a clinician here, just keep in mind, like, there are a lot of times where we don't really know if things are going right. We might know if things are going really, really wrong, but it's really important for us to get that validation or that feedback that things are going as expected or not. If things need to change, tell us why. Explain it to us. Explain any sort of consequences that might affect our daily lives. Again, that G-tube to a J-tube, that's going to affect how you can do your feeds. That's going to potentially affect your day-to-day schedule. What are the alternatives? So definitely making people aware of the alternatives that are available. Even if the alternative is just choosing to not do something, what would that end up looking like? What should we look out for, and who should we contact about issues? I know this came up before as well, but the more resources that you have at your disposal, like Oley, or knowing the different people on your care team, those are really essential to having any of those issues addressed as quickly as possible. So I will just leave us with this last thought, that communication is key. I want to know what your experience is. I would hope you would want to know a little bit about mine as well, but again, if you're the patient and I am the healthcare professional, it is about you. There's a lot going on behind the scenes that might affect what I can or can't do for you in that moment, but it is about you ultimately. And I think it's really important that we remember we're all doing the best that we can with what we have. And we're all in that network together, being influenced by each other. So really just trying to support each other, and that is important. So thank you.
Good afternoon, everyone. Okay, now it's my turn. I jumped the gun before. Okay. Good afternoon, and thanks for sticking with us on this amazing day. My name is Dr. Jill Genua. I have the absolute privilege of being a physician in the practice that started the Oley Foundation in Albany, New York. And it's really my great honor to be here today. And I want to thank Beth Gore for giving me a little extra time with you. I was initially scheduled to present one talk. I'm actually going to be giving you two talks because the speaker who was to speak about transitions is not here today. And so again, I'm happy for this time with you. If I can get this to work. Not advancing. I'm not getting paid for this, to embarrass myself by not being able to work this. Yes, I'm pressing the green. Yeah. Okay. So a lot of this we've spoken about already, and I'm happy to give you my perspective. Up until about a year ago, just over a year ago, I was what I call a normal colorectal and general surgeon, as normal as we can be. And it was about that time that they asked me to come to Albany Medical Center to take over for a certain group of patients who needed a physician, and these patients were our patients on home parenteral nutrition. And so what started as a very small job has now blossomed into my passion. And this is entirely what I do now. I work in the nutrition support field, and really this has taken over my entire practice. So after being what I call again a normal surgeon for 20 years, this is really just such a unique opportunity, and I'm learning so much from all of you. I hope you learn a little bit from what I have to tell you today. So this first talk is about transitions. And we've spoken a lot about this. I'm happy to give you my perspective, and I hope that you'll learn a few things from the way that I see how things sometimes just sort of fall apart, and how fragmented things can seem and be, and how we can empower ourselves in this field. So what are transitions? Very broadly, transitions are basically when people move across the healthcare setting. It requires a lot of coordination to move, as you all know, and there are a lot of crucial moments, and there are a lot of gaps and barriers at every step along the way. So these are some of the transitions that I think of. Certainly, we talked a lot about when someone is admitted to a hospital. This is obviously a big one. But what I see is during a hospitalization, while somebody is admitted, there are so many transitions that take place. So moving from the emergency room to the floor, During your hospitalization, your nurses change shift. Your physicians change shifts, right? So at our hospital, every Monday, the entire care team for internal medicine switches. So if we have patients for several weeks, every Monday morning, they are getting a completely new team of residents, primary care doctors, and specialists, except for me, I am the consistent one. And so I see how this affects everyone, and every Monday there's so much anxiety around these changes and so much explanation that has to go into every step of the way. Admission and discharge communication or lack thereof between teams. I have missed a lot of this conference because I've had to jump out and get on a call and pick up the phone and explain to a team exactly what's going on that I know that they missed and some details that I know I need to provide. So there are big moves and big transitions. These are obvious when you move from one place to another, a nursing home to the hospital, hospital to home. Aging is another transition that I see, and this is a big one that I see with my patients because I have inherited the patients from Dr. Lynn Howard, who started the Oley Foundation with Mr. Oley. And those patients have been on home parenteral nutrition and home enteral nutrition for over 30 years in some cases. And they are aging, and they are experiencing the changes that come with normal aging, but they're much more complicated to deal with when you require enteral support or parenteral support or are dealing with things that many people don't even think about. I have a patient right now he's been on TPN for 33 years at home, and he is 86 years old. And he has quietly lived with this. His children had no idea what he did in a day, in a 24-hour period, to sustain himself and to manage this and to coordinate his care. And now he needs a little bit of assistance, which turns out is a lot of assistance because his family really had no idea. This was just part of his life, and he did it so beautifully and so independently and so privately that we are having a lot of struggles transitioning him to accept help and to find the help that he needs. And so as people age, and we will see this, there becomes a whole new group of challenges. There's also transitions from pediatric to adult care. I have the chance to meet every medical student when they're on their required surgery rotation, and I get 1 hour to teach them about nutrition. And I usually try, I see them sort of look away. This is going to be the easy lecture. They're going to take a little nap. And I turn up the lights, and the first thing I do is tell them this story. And it's the story of an 81-year-old man who had a very long hospitalization. He had a cancer diagnosis. He was in the VA. And after several months of surgery, recovery, bouncing back from complications, they said, "Congratulations, you can be discharged home." They transported him home. And he went home, hadn't been there for months, and basically did not have anyone. His refrigerator was empty, and he ended up calling 911 because he was weak and he needed help and he had no food. And so I use this to kind of grab their attention because how often do they think about what happens when someone goes home with respect to nutrition, right? We have trauma patients who come in. They didn't know the day that they were injured that they weren't going to be home for 3 months. We're so excited when they get better and we're going to send them home, but we don't always think about what's going to happen when they go home. That does have a happy ending, by the way. He called 911 and got an immense amount of support from his community, so there is a happy ending to that. But we know that, it's not just the need for nutrition support when it's already known that nutrition support is needed. It turns out we're not very good about talking about nutrition in general for hospitalized patients. So here's a 2019 study. They looked at patients who were discharged from the hospital who had been seen during the hospitalization by a dietitian and identified as at risk for malnutrition. And when they left the hospital, about 47% of them got instructions that never even addressed the issue of malnutrition, and 45% received inappropriate instructions. So we know we have to do better there, and here's a larger study from 2015 where they queried caregivers and patients who were over the age of 65, and what we learned from that is that patients, and you all know this, we want more information. We need more information. And it needs to be understood that nutrition is very important and we need more information. We also demand more from our community. Sometimes there are resources we don't know about, and sometimes there are a complete lack of resources. So all of this needs to be identified. One transition that seems to be very well defined is the transition from being in the hospital to home with parenteral nutrition. And as Dr. Mercer mentioned yesterday, there seems to be a lot of resources that the hospital will invest to get you home, right? So it's kind of easy to make these checklists. They're complicated and they're long, but they exist. That process of going home on parenteral nutrition seems to be defined. We're able to say, first you need the insurance authorization, then you need this, and it's a big checklist. But I'll tell you what, it doesn't make it any easier, and it doesn't make it any better, and it doesn't make it any less prone to complications. So I live in this space a lot of my day, trying to get patients home safely. This is a big transition, and it's not easy, but it is very well defined. One of the other transitions that is written about a lot and was really a big part of my life when I was a colorectal surgeon 100% of the time is this idea of transition from pediatric to adult care. This is pretty well studied. I think we have a lot of work to do, but I think the good news is that there is a lot of work being done in this space. And then there are what I call the quiet transitions, which, having spoken to patients in my practice for over a year and really focusing on nutrition support, particularly home parenteral nutrition and home enteral nutrition, these are the transitions that I have gone through with my patients, and these are not necessarily things that show up in a chart. They're not necessarily things that we write about, and they're often things that are dealt with very quietly. And this can be life changes, getting married, having a new relationship, having a relationship end, a new job, a career change, going to college, moving or relocating, becoming a parent, aging or frailty of your caregiver, loss of a caregiver, change in insurance. There's nothing like when you love your enteral formula, you're doing great on it, and all of a sudden the insurance company decides they're not going to have that on their formulary anymore. We deal with that a lot. And also physician-provider retirement. So in my practice, patients were very, very happy that I took over, but what I see is that sometimes I'm the only one that's left taking care of some of these patients. So they have multiple specialists who have known them for many years, and the cardiologist retires. And guess what? There's nobody to replace that cardiologist that truly understands what that patient has been through. And so the patients will often come to me and say, well, can you just do it? Can you just prescribe these medications? And it's hard for me too, because I want you to have the best comprehensive care. But I'm often alone in this, and I'm often left sort of trying to figure out, who can we get on our team here? And then there's society transitions, fluctuating reimbursement, shifting priorities of funding, and all the shortages. So what are the barriers to fixing these things? What are the barriers to getting over it? So what I call the I in team, this refers to the never-ending staffing problems that we have everywhere. So when I came to Albany Med, they said, would you lead our nutrition support team? And I said, yes, I'm available for that, right? I'm the only one on the team. So, and they rub this in my face. Every time we have a meeting, they say, oh, now can we have an update from the nutrition support team? And I say, yes, there's no I in team, but the team is I. I am the nutrition support team. So I've had to overcome this because, as it turns out, there's so many staffing shortages that nobody can donate a person to be dedicated to my nutrition support team. So the pharmacists can't leave the pharmacy. The dietitians have a lot of other things that they have to do, a lot of patients they have to see. So what I've had to do is create virtual teams. And so this is working for now. But again, there's a lot of, everyone's doing the best they can. I truly come to work every day and know that everyone is doing the best that they possibly can. But the team is I. We're also not very good about discussing nutrition or malnutrition in general. So a lot of times I will cringe because my residents and many other people assume that every patient who comes into the hospital who is on home nutrition support is malnourished. And that's not necessarily the case. If you are doing very well and you just happen to come in the hospital for an unrelated issue, everyone wants to label this patient malnourished. And so we're not very good at discussing it and defining it, and hopefully we'll get better. A lot of education gaps, and there's always a constant lack of resources. So how can we ease the tension of this? I sort of summarize it with these words: engagement, vigilance, persistence, patience, connection, and confidence. So we've got to stay engaged. We cannot give up. We've got to keep pushing. We've got to be persistent but patient. Things take time. So like I said, lead the team. I still have no team a year later, but I have a dozen more very strong connections, and I can more effectively take care of the patients with those connections. These are my references. So I would now like to introduce myself to give the next talk, as we run out of time here. Still Dr. Jill Genua, still from Albany Med, still very, very, very happy to be here. This is the talk that I had originally planned to give you all, and I wanted to speak about sort of my view of the communication barriers in this very complex environment, and how we can better communicate, better express ourselves, and also encourage clinicians on how to really listen properly to our patients' stories. So when I was in medical school, I rotated with an internal medicine doctor who was absolutely fantastic. She was engaging, she was smart, she was bright, and every patient left her office feeling better. And I don't just mean like physically better, I mean they felt better for having been to that office visit. And I really liked her. And one day she came in and she said, I read this book and I really think you're gonna like it. And so she gave me this book to read. I don't remember much about it, but I always remember how it starts. And it starts like this: we all have our stories. This is mine. Many lives progress in a more or less predictable path, like water through a well-marked channel. My journey has been different. Well into adulthood, I was never supposed to be what I became. So the first story I'm going to tell you, I call The Game. And these pictures were taken exactly when this story occurs. So my son was about 7.5, 8 years old, and his school organized an old-fashioned block party. So my husband, who's also a physician, was on call that day. So my son and I went to the school. And it was just one of those beautiful fall days when the sky is like perfectly blue and all the colors are really bright and crisp and the sun is really warm on your face. And they had all these cool things set up. They had a dunking booth, they had three-legged races, bouncy houses. And one of the other things that they did was they organized a lot of little like times for different games. And so they had a time set up for a soccer game. One of the fathers had volunteered to organize just sort of a friendly soccer game. So as the time got closer, my son noticed that all of his friends were getting together to play the soccer game, but it wasn't time for it to start yet. But they decided they were going to start playing. So my son puts on a jersey, they split themselves up into two teams, and they start playing. And I know this is a blurry picture, and it's from far away, but you can see, my son is the one in the orange and the blue hat, and if you look really close, you can see him with a big smile on his face, and he was having the best time. So I'm watching this go on, and then the time of the official game comes along, and the father comes, and just through numerical chance, he divides them into two groups, and my son gets completely separated from his friends. So he gets put onto a team with kids who are older than him, they're faster than him, they all know each other, and he doesn't know them. And they start playing, and I'm watching, and they're not passing the ball to my son. And my son is desperately trying to get their attention and doing everything to kind of like get into the group, and they just wouldn't let him do it. He just couldn't do it. So a few minutes later, he looks like this. And I notice his shoulders are really, really tight, and his hands are kind of like bunched up into little fists, which is what he used to do when he got nervous. And you can see his body is sort of going one way and the other. He was really just not having a good time. So I went down to the sidelines, and I called him over, and I said, hey, Maddie, you know, there's a lot of fun things going on. If you're done playing soccer, we can move on, right? We can go somewhere else. And he sort of like looked at me, looked back at the game, was wringing his hands, and he said, yeah, okay, I think it's time to move on. Let's go do something else. But first, let me go give back my jersey. So he went to give back his jersey, and I see him looking, and then he kind of shakes his head, and he comes back, and I go, let's go to the dunking booth. So we start walking, and he's very quiet. And a few minutes later, he says, you know what the worst part is, Mommy? The worst part is that I bet no one even noticed that I left the game. And I've thought about that a lot, because no matter what brought you here today, I'm sure that you can think of a time when you have felt the way he did that day. Just invisible, like no one really noticed that you're there or walked away. All of us have felt that at some point. And what he was actually describing was, no matter what you call it, a form of loneliness. And this is something that we've talked about a lot in healthcare the past couple of years. And, officially it's defined as sort of this subjective feeling of being alone or social isolation. And in the studies, sometimes they talk about it in older populations of people, but the reality is it affects everybody. And I also used to think it was more common after the pandemic, but studies have also shown that it has always been there. I'm not the only one to have had this realization, by the way. One of our Surgeon Generals spent some time when he first took office speaking to a lot of Americans. And he basically said that, no matter, I can't even read this from here. Oh, I made my print too small. My God. This is how old I've gotten. Anyway, he said that he traveled all over talking to all these people, and he just never realized that loneliness was such a problem. But over and over again, he would hear from people, I feel like I am the only one shouldering this burden. I'm the only one who feels this way. And if I were to just walk away, would anyone even notice what I did or that I was important? And again, I think there's a lot to that, and I think we've all felt that, no matter what our roles are in this game here, right? So when I first was when I was in medical school, they'd make you take this class, basically like how to do a physical exam. And I always remember this so distinctly. They would teach you that when you were going to listen with a stethoscope on someone's chest, that before you did that, you should stand on the patient's right and put your left hand on their shoulder, rather than just sort of like coming at somebody with a stethoscope and making them just be startled. Just establish a little bit of a connection by putting your hand on their shoulder before you placed the stethoscope on their chest. And I always remember that. And it seemed like for a long time at the beginning of my career, that was a very important part of practice, right? That somehow establishing a connection, and often it would involve touching the shoulder or shaking hands. And when I went into surgery, this was also a really big part and has been a really important thing for me. So the anesthesiologist knew, especially when someone was having a big operation, that when they would go into the operating room, that I wanted a few moments with that patient to hold their hand, look at them, and be with them before they fell asleep. And this was something that was very, very important to me, and something that I felt and hope helped those patients as they went off to sleep. And then the pandemic hit, and all of a sudden, there were not only physical barriers between us, but it was also dangerous to be in someone else's physical space. It was actually life-threatening. And so this has really changed things. And if you felt that isolation, I promise you that we felt it too. Okay, so they talk about physician burnout. Burnout is not working too hard for us. Burnout is that feeling of isolation, that feeling of not being able to connect, and that feeling of just not being able to do enough. So how do we connect now? Now things look a little bit different, right? So there's usually a screen of some sort, sometimes more, involved in our interactions. And not only that, everybody is so distracted, right? So things are always beeping, things are going off in our pocket, someone's always texting us, calling us. There's so many things distracting us from what's important and from that encounter that we're having. So the good things that have come from this sort of change is, well, number one, especially after the pandemic, we've got good technology, and this allows many things. So if you live 3 hours away from me and you need an office visit, we can connect virtually. That's great, right? You don't have to sit in a waiting room any more than you have to, and we can always connect. So there's really a lot of inconvenience that's eliminated, minimize a lot of wait times. Portal messaging, so you can reach me, and my patients can reach me for good and bad. So whereas before they might not necessarily have called me if something good happened, but they can send me a quick message, and so it's really an easy way of communicating. And we've gotten better at electronic records. But here's what doesn't feel so good to me. So the lack of a physical exam does bother me. So you may think, oh, there's nothing to see here. I'm fine, I'm doing well. And I can tell you, there are a lot of people who have come to an office visit with me and they're doing fine. But I look and I see a rash, or I see a little bit of redness that they didn't notice, or I feel a thyroid nodule, or I hear a heart murmur. There's a lot of different things that I can't pick up on virtually. And I miss clues. Sometimes I feel like I'm missing the opportunity. There are a lot of times when, again, everything's going fine, we move through an office visit, and I see just something seems off. And so I just need the opportunity to say, is everything okay? Is there anything else you want to talk about? And virtual visits, you can sometimes miss that. So there's a lot of that barrier between us in terms of screens and distraction. And the other problem is that newer physicians, as I try to explain to them these things that they're missing and teach them how to have these connections, they've never seen it any other way. They've never lived in a world where communication is not texting, where they actually had to pick up the phone. So these are some of my solutions to the problem. Again, this is from my perspective as a physician, but one who has been very much in your world and honored to do so for over a year. I am not perfect. I have a lot more to learn. But these are the things that I have found helpful. Staying organized and being prepared. So if I am seeing a patient who has been on parenteral nutrition for 25 years, I need to prepare for that visit. I need to learn the history. I need to see who's on their team. I need to see what's going on, and I need to invest that time up front. So Dr. Howard, I was recently able to meet her and ask her for advice on how I could be successful in this world and in this nutrition support world. And she told me, you have to keep pushing. You have to keep pushing and you cannot give up. People are gonna try to push this aside, say it's not important, but you have to keep pushing. And I think of that every day. Actually, my nurses got it put onto a plaque and it's hanging over my desk now because I say it all the time. You've got to find the right person for the job. There are some people that just want the easy stuff, and they shouldn't be on our team, okay? Build your team with people that work for you, people that are on your side, and that you feel very comfortable with. I have to do the same thing, right, when I build my team. This is my approach. Again, I am not perfect. These are things I try to teach the residents and the medical students that come with me. I learn something unique about each and every patient at every visit. And I record it in the chart. It helps me remember everything, and it helps me just learn a little bit more about that person and be I hope, a better caregiver for them. At the end of every visit, trust me, I have a lot of things I have to fill out. We have a lot of data we have to collect. We have a lot of things we have to do. And there's multiple screens and multiple things and papers. And it's for 60 seconds at the end of every visit, I push all of that aside and I just look at that person like they are the most important person in the entire world. That doesn't sound like a lot, but sometime today, try it. Just sit with somebody face to face, set a timer for 60 seconds, and I promise you, you will realize how distracted we normally are in a day. Invest the time. I had to work at this one. Ask questions and then pause for the answer. This was very hard for me. I was one of those doctors who would ask a question with all the answers, right? Okay, are you better, worse, or the same? Is it like high, low, or the same? You know, I'd give them, and the patients would sort of be like, wait. And then I realized I had to slow down, and I had to ask the question, and then I had to shut up, which is very hard for me. But it does make a huge difference. Nobody hears thank you enough. No one gets congratulated enough. Everyone's quick to complain, but it really goes a long way if you can just say thank you. And especially, I'll tell you a story. When I was on my way here, I was reminded of all of these things. And it was even after my talk was done, where I have a patient who came to me a year ago. He had been a long-term patient. He may have even been Dr. Howard's patient, and then he was Dr. Mikulic's patient who came after her, and I sort of inherited all of these patients after. And he's been so difficult. We've had a very difficult start to our relationship. He doesn't get his labs done. He doesn't take his B12. He doesn't return phone calls. He doesn't show up for appointments. It's just been really, really, really challenging, and I've tried every single thing with him. So he was my last appointment before I left for Oley conference. And I had to take like 10 deep breaths before I went in. I'm like, okay, we're gonna do it. So I opened his chart, and he had done every single thing that he was supposed to do for this visit. He had gotten all the labs, all of his meds were refilled, everything was good. He hadn't skipped any infusions. He had been answering all of our phone calls. And I was so excited. And I walked in, and I said, I wish I had a prize box. And he looked at me, and I said, you deserve a prize. And he said, why? And I said, because this is the first time that you've done every single thing I needed today. And he immediately just shut off. He rolled his eyes, he picked up his phone, and he just sort of went like, here we go, now she's gonna, it just didn't work. Okay, my approach didn't work. And I said, I really need to change gears here. So I sat down, and in my room, there's sort of half looks like a normal exam room. The other half is a round table where we usually spend a lot of time talking. And so that's where we were, and we sat across, and he said to me, I just want you to know that, I've been sick since I was a baby. And first, when I was a baby, everyone told my mom I was never gonna survive. And then when I was growing up and I needed TPN, all I could overhear were people and doctors telling my mother over and over again, he's just not going to be able to survive this. He's going to have a complication. This is very complicated. And over, that's what I heard. And so I just decided at some point that I was not going to have a normal life, and that I should just not even hope for anything or really desire to do anything when I grew up, because I wasn't going to get that chance. And then I remember Dr. Mikulic meeting my mother and talking to her for 3 hours, explaining what parenteral nutrition was, how I could do this for the rest of my life. And from that moment forward, my life was never the same. And so for you to come as a new physician, after all that time, when I finally have the life I want, it's very, very hard for me to even think of anybody who might change something, or even just a little bit, and change what my life has become, because I never thought I would have this life. And I promise you, it changed our entire relationship in that moment. That story that he told me changed everything about everything that I've ever seen. And so that is really one of the major points I wanted to bring out. It's been mentioned several times to tell your story, but I wanted you to know how much it means to us as your physicians, as your caregivers, as your providers, whatever you want to call us. Your story is much more powerful. If you ever feel like your history is too complicated to explain, your medications and your regimen are too complicated, just tell us a story, because I promise you it will work. Crying is acceptable, by the way, but not on the way out. So people always apologize to me if they start crying, and I say, you can cry as much as you want here, but when we walk out, you can't be crying because you'll scare everybody else. And that's bad press for me, but, and my staff knows this. Sometimes we're in there for a while, we come out, and they sort of look up, and then I'll see someone's eyes start filling, and I know we're not done yet. And I say, we're going back in. And my staff is like, they're going back in, round 2. So that is the invisible touch, okay? So even if you're on a screen, or you feel like you're physically isolated from somebody, or you're in this complex system, that is the invisible touch. Tell your story. Thank you so much for being here, for listening. Sorry if I went over. Any questions?
Thank you all so much I know we went over a little bit on time, with the big takeaway here being just the power of connections.